Me. This is exciting. So I'm just gonna introduce myself and talk about podiatry in general, how I got to decide on being a podiatrist, um, the schooling, like everything about podiatry school, from when I was in school. That was like over 10 years ago. And what I'm doing today, what I'm doing now, how I'm practicing. So my name is Dr. Oteri-Tsague. I'm a podiatrist or foot and ankle specialist. So what a podiatrist does is we diagnose and treat any pathology of the foot and ankle, any pathology at all, from dermatology to surgery to medicine, just any pathology at all. Is the internet out? Can you guys hear me?
Yes, everything's good. We're here.
Okay, good. So basically, what I do now is I own a clinic in Richmond, Texas, a small clinic. I also am affiliated with the hospital down the street from me. The name of the hospital is Oak Bay Medical Center. So I treat patients in-house, or when my patients come into the clinic and they're too sick to be treated in the clinic, I send them to the hospital to be admitted, and then I manage them in-house there. I also do surgery at the hospital and at a surgery center. If the procedures are very minor, like ingrown toenail surgery and removing plantar warts and stuff like that, I'll do it in the clinic. But if the procedure is a little bit more advanced, I'll take it to the hospital. For example, like if a patient has like a deep abscess in the foot and everything needs to be drained out, or if a patient needs an amputation, or if the patient has a fracture of their foot, all that good stuff, that has to be done in the hospital. So a little background about myself. I went to the University of Houston. I did my undergraduate there. My bachelor's was in health and human performance and biology. When I was in college, I knew I wanted to go into medicine, but I wasn't quite sure what field I wanted to do. So I did have a slight interest in sports medicine, physical therapy, chiropractic, rehab, all that stuff. The reason why I was interested in that is when I was in University of Houston, I was part of the Shotokan Karate Club, and I was the president of the club. And I used to compete in state, national, and international championships in Japan for University of Houston. And I was always interested in helping with like first aid for my teammates, wrapping them up, icing, giving them advice on how to heal fast, and obviously following up with the doctor. But I was just interested in sports, sports medicine. So how did podiatry fall on my lap? I didn't know nothing about podiatry when I was in college. So I decided when I was in my fourth year, undergraduate at University of Houston, I went to speak to a counselor. And I went to speak to a counselor, and she talked to me about different specialties. She talked to me that kind of have something to do with sports medicine. She talked to me about physical therapy. She talked to me about chiropractic. She talked to me about just sports medicine in general, like MD. And then she mentioned podiatry. And she said there is a sector of podiatry that focuses on sports medicine too. And I was like, what is that? She got me to see that there was a podiatrist in the medical center then that was the doctor for a women's team. So she called a doctor to see if I could shadow him, and he was very, inviting, and I was invited to his office and I shadowed him. So he showed me that he not only focused on sports medicine, but he did other things, and he was a podiatrist. He did other things like diabetic limb salvage. He did other things like pediatrics, which is podopediatrics, taking care of kids or children's feet, like congenital deformities, um, um, things like foot pain, flat foot, Severe's disease, which is inflammation of the growth plate, the calcaneus in children, which is very common. Just different pathologies different pathologies of the foot in children. So I was just so amazed at how broad podiatry was, but it was such a small subspecialty too. So it was like contradiction. Like not a lot of people know about podiatry, such a small field, but there's so many things within the field of podiatry. So I was like, this is quite interesting. Yes, I'm trained to treat all ages. I actually treat from the youngest I have treated is 2 years old. When I shadowed him for like 3 days. He was very inviting, very warm. I felt comfortable asking him any questions. And he was actually the one that made up my mind to pursue podiatry. So that's why when socially distanced, the ladies from socially distanced shadowing reached out to me, I was very to speak to you guys, because I remember how it is, how it was when I was looking for help back then. So anyways, he opened my eyes to see how broad the field of podiatry was. He even took me to the OR that day. And I was like, what? They do surgery too. I think he did surgery on a bunion. That was the surgery I shadowed that day. Obviously, I didn't scrub in, but I watched, and I was just so amazed. I didn't even know what a bunion was. I mean, I saw people with bunions, but I didn't even know it was a deformity that had a treatment. Anyways, I was intrigued, and then I went home. I did more research. I found out that there were 9 schools in the United States, 9 podiatry schools, and I was like, where do I think I'm from Texas, obviously. And I was like, where do I think I want to end up in? And I was like, Miami, Florida. I didn't know anybody in Florida, but I was like, okay, there's one school in Florida. Sounds good. So I'm just gonna apply. I did do MCAT. And to be honest, when I did my first exam, I was not happy with my scores, but I talked to the doctor about it, the doctor that I shadowed, and he said, you can retake the MCAT, or you can still apply with the scores. Just go with it. Believe in yourself. You have a well-rounded resume, which is one thing I'm going to let you guys know. They not only just look for your MCAT scores, but they want to see how well-rounded you are. So on my resume, I was the president of the Shotokan Karate Club. I used to do a lot of volunteering. I shadowed not only the podiatrist, I also shadowed a physical therapist. I shadowed a chiropractor. So I tried to show that I was a well-rounded student. And my GPA was about 3.7, which, I mean, it's my MCAT wasn't that great. GPA was, I would say, decent, because there's higher GPAs. I don't know if that's I know a lot has changed since I graduated. I graduated college in 2009, University of Houston, and then I graduated podiatry school in 2010. So I know a lot has changed. I'm sure MCAT scores is not the same anymore, or maybe GPA is not the same. I'm not sure. But anyways, it was like a 3.7. I thought it was decent. My science classes, most of them I got B's and A's. I think the one that I got a C in was physics, but who cares about physics? But anyways, I still applied. I know I look young. Even all my patients say that. They're like, "Wait, are you the doctor?" I'm from a Nigerian family, so I don't know if there's any Nigerians here, but my parents didn't play. So, anyways, I applied and I got called in for an interview. Yay! I got called in for an interview and I went to the interview. I was very nervous. My dad and my sister went with me, and I practiced a lot with my sister. So, if you have somebody that you can practice with, just, practice with them. Thankfully, there were two sets of interviews. There was, two groups interviewing. The first group, I heard they were very, laid back. They would ask a lot of like personal questions. They wanted to see how you were as an individual. And then the other group, they were very like strict and just they were really focused on your grades and, very academic, right? So thankfully, I was put in a group that was very like laid back and, they just wanted to know more about me. And I just felt very comfortable in the interview. Just fast forward, I got accepted into the school. I got a little bit of scholarship as well because of, I think if you made like a GPA of 3.5 and above, you got a little bit of scholarship. So that was good. And I was like, Mom, Dad, I'm moving to Florida. So, and that's how that happened. So when I was in school, when I was in podiatry school, we'll talk a little bit about podiatry school in general. So it's 4 years of medical school, just like regular MD or DO. The first 2 years focuses on just general medicine. So it mirrors the same thing as an MD program. So we did like, we did anatomy, general anatomy, we did histology, we did pathology, we did biochemistry, we did physiology, just the same thing that you would see in the curriculum of an MD, right? And then the next 2 years, the last 2 years, so it's 4 years, the next 2 years focus more on podiatry and then externships, like going to hospitals to rotate through like clinical rotations. In podiatry school, there are 2 sets of board exams. So in your second year, you'll do your first board exam, and that's clinical. So it's a combination of things like, what I talked about, histology, biochemistry, anatomy. That was the boards part 1 focused on that. Then boards part 2 focused, in your 4th year, you will take boards part 2 to be able to graduate out of school and get into a residency program. If you don't pass boards part 2, you cannot match into a residency program. I would say getting into podiatry school is not as hard as getting into like regular medical school. I mean, I think my MCAT scores I could have done better, to be honest, but I still got in. Staying in school is hard. It was very challenging. Just because it was easy to get in doesn't mean that you don't have to work your butt off when you're in school. So it was very, very challenging. But anyways, I passed boards part 1, boards part 2. Then when you pick your externships, you want to pick your externships keeping in mind what kind of podiatrist you want to be when you graduate. In residency, the residency programs tend to pick students who had externed with them in the past. So if you know, okay, this program, the residency program I ended up in was Palmetto General Hospital in Miami, Florida, because they were heavy into surgery. And wanted that. I wanted to be well-rounded. I wanted to know everything because I knew that when I graduated, I wanted to own my own practice. And to own your own practice, you have to be very confident in what you're treating, right? So I decided to go to a very rigorous program, residency program. So it's always important to kind of choose. You get to choose what externships you go to. It's important at that stage to choose what externships that you would see yourself spending your residency training in for 3 years. So I decided to go to the hard externships, and luckily I matched at Palmetto General Hospital. Palmetto General Hospital, so residency in general is 3 years. Once you graduate from residency, you have the option of subspecializing when you're done. There's a fellowship also. There's wound care fellowship. There is sports medicine fellowship. There's Podiatrics. Pediatrics, obviously, if you match it together, is taking care of children's feet. There is what else? I think those are the three main fellowships. I decided I didn't want to go into fellowship because I felt like I was trained enough. If you feel like you need more training, you can go into fellowship. And some people just think of fellows as even more distinguished and more, they have more knowledge in whatever field that they decide to go in. So if you feel like you want to be in that category, then go ahead and do that. But when I was done with residency, I was like, I don't think I want to do fellowship. I want to go ahead and start working and start my career and start my own practice and all that good stuff. So I finished residency in Palmetto General Hospital in Florida. How did I cope with Spanish? I just coped. I know how to speak a little now because I was in Miami for technically 7 years, and I'm answering Sania's question, but I just coped. I just learned little things like ¿Cómo se siente? How you feeling? ¿Dónde duele? Where hurts? And the patients are very sweet. I was in a Cuban community, and their culture is quite similar, I think, to Nigerian culture. So I don't know, I just assimilated. It's easy for me to just assimilate with a culture because I'm easygoing and I don't know, I'm just jovial. So I just went with it. Anyways, where was I? Residency. In residency, the first year of residency, I would say, is the most challenging year. It will try you. Some people, I know some people who stopped, they just quit because the first year of residency is sort of like hazing, if you will. You're in charge of taking call, you're rounding in the hospital early in the morning. You are like the bottom of the, apart from the students, you are like the bottom of the pool, I guess. So you're doing everything. It's hard because you're tired, but it's also good because it builds you up. Like I feel like I can do anything. I don't know if have you ever felt like you feel like you can do anything, and I have my residency program to thank for that. Anyways, the first year of residency, you're doing everything. You're rounding on the patients on the floors. You are taking ER calls, so any trauma relating to the lower extremity, from fractures to diabetic emergencies like gas gangrene, all that good stuff, you're being called in to take care of. You're always answering to the senior residents. You are also managing the patients in-house. You're setting up for surgeries. You're cleaning up after surgeries. You're also participating in ground rounds, and you also have to present. It rotates from resident to resident, but there'll be a week where you're in charge of presentation on a certain topic in ground rounds. So it's very intense. The second year of residency, I believe, is the best because you feel a little bit more comfortable. First year, you're like, what the heck is this? And you're still trying to find yourself as a doctor. It's like you're an imposter. And then for somebody like me, I look like I'm 12 years old, so it was even worse. They're like, wait, are you the doctor? But uh, you get used to it. Then second year, you start to, feel yourself. You get a little bit more swag. You're like, I got this. I know where the OR is. I can look at those students. They don't know what they're talking about. You start to feel like better, right? Then the third year of residency is when you start to worry about what I'm going to do when I get out. Am I going to get a job? You have to also start teaching the first years and the second year. So the attendings, they require more of you. And you have to start doing more complex surgeries like ankle fractures and pylon fractures and using external fixators, things that are more intricate. Okay, so every level has its pros and cons, but overall, I did enjoy residency, and I felt like it's best to go to a residency program that is hard, because when you get out, you feel like you can do anything. So that's Jamisha. Yes, you perform residency straight. You perform surgery in residency. It depends on the residency program, but for my program, day one, I was placed in surgery rotation. Day one, I was given the knife. You better study before you get in there. You better read up on it, and you better watch those YouTube videos. I was given the knife. Every attending is different, so you get assigned to a different attending with each case. So every attending is different. Thankfully, I was with an attending who I felt comfortable with, and showed me stuff step by step. They want to know that you have the confidence, because if they feel like you don't have the confidence, they wouldn't give you the knife. So that thing they call fake it till you make it. Yep, you got to do that in residency. So but they give you the knife first day. You get to work. You get to work ASAP. So yes, you start doing surgeries, and as a first year resident, the surgeries that you start doing they get you comfortable with things like applying grafts, learning how to suture, draining pus, correcting hammer toes. Let me see, do I have my foot in here? Correcting digital bunions and hammer toe contractures, stuff like that. Those, quote unquote, easy things. Those are the stuff that you start doing as a first year resident. Second year resident, they want to know that you're following the steps better. They also want to see if you can teach the first year residents, because the more you teach, the more you realize if you know it or not. So second year residents are classified as the teachers, if you will. Then the third year residents are the ones that do more intricate cases. They're hand in hand with the attendings. Sometimes the attendings might be nervous about the case, and they will do most of the case, with the third year as the one who's just behind them through everything. But generally speaking, the third years do more advanced cases like calcaneal fractures and comminuted ankle fractures, stuff like that. So that was residency. So, and then in between, I think second year of residency, you also have to do other rotations like pathology. So I had to do pathology rotation. I had to do the pathology. What else did I do? Internal medicine, internal medicine rotation. I had to do ER rotation. I had to do psych. That was my least favorite, but hey, I had to do psych. Like I didn't like going to psych, but hey, you got to do it. What else? My favorite rotation was to Dr. Pratik. My favorite rotation was pathology. I loved pathology. I don't know. I felt like if I didn't do podiatry, I would have been so interested in pathology. I also liked, we had to do radiology as well, because as podiatrists, you have to be able to read your x-rays without the radiologist. We are trained, like you have to know how to read your x-rays unless you're not a real podiatrist. Read the x-rays, you have to know how to read the MRIs, you have to learn how to read the CTs. Maybe the things that we get help on is clarification on like bone scans. And maybe if we are not very too sure on what the MRI says, then we will consult the ER physicians. But you have to, radiology was really good because you just have to know how to read these things. So yes, podiatrists do it all. So when I graduated, okay, so let's fast forward. Residency is done. I got done in Florida, and I came back home to Texas. I worked with a group for a year because I wanted to just get my feet wet. I wanted to just feel, when you're done with residency, you still feel like a resident. FYI, you don't just sleep and wake up and you're like, haha, I'm the doctor. No, you still feel like a resident. So when I finished residency, I decided to work with a group for 1 year so I can feel more, feet wet. Y'all are funny. I wanted to feel a little bit more comfortable. I wanted to see how the groups were going about running their clinic. I also, when I was in my 3rd year of residency, I also shadowed in physicians' offices who I felt were really good with practice management, because it's one thing to be a doctor, and then it's another thing to own your practice and know how to do good practice management, because you can treat everybody but still be broke. Okay, so you have to know how to run a clinic. So I knew in residency, the 3rd year residency, that's something I wanted. I wanted to be my own boss. I wanted to run my own schedule. I wanted to build a legacy for my family. I wanted to just be a boss. So I decided to shadow a lot of physicians who I saw. Dr. Smith, he's really good with running his practice, and he started from the ground up. So I did that. It's always good to find mentors and find people that you feel are easy with giving you information. And anyways, I do that. If you feel like you want to start your own practice during residency, make sure you link up with other physicians who have done what you're trying to do. Anyways, I worked with a group for a year. It was okay, but I felt like I was being lowballed, but that's fine. You're still a resident when you get out anyway. Then I went ahead and started doing a lot of research on how to start a practice. I got my license. I registered the name of my practice. I found a small clinic I found a small office space close to the hospital that I'm in board with. And I just set it up. This is one of my exam rooms. I just set it up liking, and I just started hustling. I just started doing it. You just have to believe in yourself. It also helped that everything came natural with me, the way I treat people. I just treat people like sincerely. You know how people say, oh, I treat people because I love them, and this is like sincere. I just treat people like how I would treat my family. Like whenever I'm treating a patient, we have fun, we talk, sometimes the patients don't want to leave, especially the older patients. They don't want to leave because they just like even if it's a small clinic, it feels like family. It's so funny because last week, one of my patients, she's 87 years old, and she's diabetic. So routinely, I see diabetic patients every 3 months. And so I had just seen her recently, and then she scheduled an appointment to come back. And I was like, Mrs. Smith, she's not scheduled up to come back until like next month. Why is she on the schedule? And it said foot pain. So I was like, oh, okay, so bring her in. And she came in and I was like, hi, Mrs. Smith, how are you? I'm not supposed to see you until next month. Is everything okay? She's like, honestly, doctor, there's nothing wrong with me. I just wanted to come in and see you. I just wanted to say, oh, how is your daughter? Do you have a new picture of her? How is your husband? I just wanted to chat with you. I was like, oh my gosh. But you see, like that, she felt comfortable enough to she even paid her copay to just come in and talk to me. Like, I was like, Mrs. Smith. But anyways, I just treat my patients like family. I think that's why my practice has, grown. So anyway, let's go back to podiatry in general. Podiatrists do a bunch of things, like diabetic limb salvage, which when I was in school, I decided that is what I am interested in. I just saw the need for it. I would say a good 80% of my patient population are diabetic patients. And I would go over like 2 or 3 cases afterwards to just show you a little bit of what I do. So you guys know what diabetes is, right? And diabetes affects the feet a lot. Matter of fact, I didn't even know how bad it was when I was in college. And even to be honest with you, in podiatry school until, we started taking the classes and we started going to the clinic. And I was like, what the heck is this? It's as common as a cold, amputations left and right, abscess left and right. It's crazy. What is this? So anyways, that's how I got interested in it. And it's just so rewarding to see how much you can affect people's quality of life by saving their foot. You don't really think about it until it happens to your family member or to, when I see a patient say, oh, thank you so much. I thought I was going to lose my foot. And I'm so, I'm so grateful. That is a lot, so I just became gradually, my passion for it built up. So that's what I see. I see other patients like, that have general foot problems like heel pain. That's a common one. Plantar fasciitis, ingrown toenails. I don't know if you guys know what that is. It's when the toenails curves into the skin and causes a lot of pain. Most times it gets infected. So we numb the patient up and take out the part of the nail that's ingrown and drain out the pus and give them antibiotics. So that's something I do commonly. Removal of plantar warts, flat foot, children. I would say for children, most things that children do come in for are like patients with flat foot deformity, and their parents want to know what to do to make sure that, club foot, flat foot deformity, plantar warts, ingrown toenails. A lot of kids do get ingrown toenails. You'll be surprised, right? So stuff like that. But I will say my practice, because I think of the area that I'm in, a lot of patients that do come in because of diabetic foot complications. And that is what I'm interested in. So it's sort of like my niche. It just so happened that I found a clinic close to the hospital. And this area is like old Richmond, old Texas, Rosenberg area. And there's a bunch of, patients with those problems around this area. So it just fit. I don't know. It was meant to be. Yeah. Let's see. Let me see those questions on the side. Do you ever recommend shoes or foot products to patients? Yes, I do. So as a diabetic patient, if you are a Medicare patient, Medicare will pay for a diabetic shoe annually with 3 inserts, because Medicare or the government has found out that they spend billions of money taking care of patients after they have an amputation. So it's basically prevention is better than cure, right? So they're willing to spend more money in preventing diabetic foot complications than treating it afterwards, because after an amputation happens, there is a 50% chance that another amputation is going to occur. So it's just a lot of money. It's just billions and billions of dollars spent on managing diabetic foot complications. So yes, I recommend diabetic shoes. I actually dispense the shoes in liaison with Medicare to the patients and the inserts. Okay, would you recommend getting an MBA for pre-meds interested in one day owning their practice? You know what? I don't have an MBA, but I feel like an MBA would have helped, to be honest. I got a lot of my knowledge from doing research, and my mom, I'm the only doctor in my family, but my mom, she's an entrepreneur. So I think I got some of her spirit, that entrepreneurship spirit from her. But I feel like if I did do my MBA, I probably would have done better on the business side. But you don't need it, but I think it will be a great addition. Do you have any advice for writing personal statements to get into med school or podiatry school? I would say, tell a story about yourself. Like, make it very personable and sincere. That's what I would say. Did you deal with discrimination and microaggressions? Oh, yes. So I did deal with a lot of microaggressions and discrimination. That also prompted me to want to own my own practice, because I control everything. I hire and fire as I please, and I only want positive people around me. In residency, especially when you're a first year, you have no choice but to take in everything. And you might not like the way some people are treating you, but because you're a resident, right now it's improved because more and more people are speaking up. But when I was a resident, I just, I didn't really speak up. I just, took it one day at a time. But that actually also influenced me to say, okay, when I'm done, I don't want to deal with any of this. I want to be my own boss. I want to call the shots. I don't want anybody talking to me the way I wouldn't talk to anybody. So yes, I did experience some discrimination, especially because I look young. I started school at a young age. When I was in school in Nigeria, I don't know if they do that here, but you skip a couple of grades if you take some exams. So I graduated school early. When I came to the United States, I think I was like 13 years old, and it was time to go to, and I was done with high school. And when I came here, they're like, what the heck, 13? No, go back to school. So I finished school early, and I have a young face also. So when you look young, when you look young and you're a woman and you're Black, those are like three things. You have to kind of prove yourself, right? So I did experience a lot of that in residency, but it's not all of that. I would say those are part of my experiences, but not the whole experience was like that. I still enjoyed residency. Okay. So I would say use that, discrimination or whatever as inspiration for your future, because that's what I did. Let's see. Let me see. What time is it? 11:45. I'm going to answer a few more questions. I hope this was thorough.
This was awesome. Thank you so much.
Okay, good.
So much.
I'm just rambling.
No, this is awesome.
Okay. So I'm going to answer a few more questions, and then I'll go over some cases that I've done, so you guys can kind of see just a few pictures, and we'll round up. Okay, let's see. Any questions? what can I do in order to get MBA? Should I do it while I'm in undergrad? So there's at Barry University, that's where I did my podiatry school. There is a DPM, because that's what I am, a Doctor of Podiatric Medicine and MBA program. So there's a conjoined program. So you can get your MBA and your DPM. You're going to take more classes. You're going to be stretched to the limit. But when you graduate, you're going to graduate with a DPM degree, Doctor of Podiatric Medicine, and MBA degree. So check out Barry University for that. So you don't have to do it in undergrad if you don't want to. Do you treat warts? Yes, that's something I treat commonly. And actually, I saw a patient yesterday that I had to take out their warts and prescribe an antiviral medication for. Did your affiliation with the hospital help build up clientele for you? Yes. So I don't know, no offense to guys, but there's something about like girl power. So there's this physician down the street. She's with Oak Bend Medical Group. And we met at because you have to do like CME, continued medical education, as a physician if you're on board. So we met there, and she's young like me, and we just hit it off. Like we were just like two regular girls talking. And she's an internal medicine doctor over there. So she sees the need. She sees a lot of diabetic patients, and she sees a need for a podiatrist. So she always like refers her diabetic patients over to me to get treated and managed to prevent diabetic foot complications. So yes, being on board at the hospital helps a lot because it's just down the street and patients can just, you know, walk over here. I'm going to answer two more questions, and then we'll go over the case studies, okay? So what? Okay, the second attendant. Okay, no. Let's see. This is amazing, learning so much. Yay. Where is my anatomy teacher from? I don't know. That was a long time ago, over a decade. I don't know if that question was for me. Okay, anyway, so I think we can, has COVID affected the practice? Yes, and yes, it has. So when this whole COVID thing started, which was the beginning of the year, right? We were still trying to figure out what we were going to do. Mind you, we're a small practice. It's me, my front staff, and my husband, who's the clinical coordinator. We were trying to figure out, like, should we stay open? Should we close? Like, what are we doing? So I think it became really bad in April. We just went ahead and closed the clinic just because there's just so many conflicting things, and we wanted to do the right thing. So we went ahead and closed, and we have a little girl, and we just wanted to be safe. So what we did is I set up the DoxyMe, where you can do like virtual consultations. And there was just a couple of patients who called in that they had like a really bad abscess and they're diabetic and it was an emergency. Then I would go in and treat them. But most of the time I will do like virtual consults. The only thing about it is podiatry is such a hands-on practice. So it was kind of hard. I would just, prescribe them medication. This hurts. Okay, take this until we open, or do this until I can see you. But most of the time it was just hands-on. So when we opened back up in May, and in the month of April, I did maybe like 4 emergency cases in the hospital. But when I opened back in May, it took off. It just took off because a lot of people were backed up. So it did affect my practice, but in a good way, because I saw a spike of patients who had diabetic foot complications. You have to stay at home and try to take care of it. Or people were just not in their right mental state. They just let themselves go. It happened a lot. So that's the way it affected my practice. One more question. And you guys can also, at the end of this, you can shoot me an email. You can send me messages on Instagram too. If I don't reply immediately, just know I'm busy. I'm a mommy too, but I'll reply you. You can also email me. I respond to emails as well. But what kind of emergency cases do you see? I see a lot of a condition called gas gangrene. Gas gangrene is a diabetic foot infection where they're affected with a strain of bacteria that can cause sepsis if not treated immediately. So we have to take them to the hospital. They have to be admitted ASAP, and we have to go straight into the OR and drain that. And gas gangrene is the worst smelling thing that you've ever smelled in your life. But if you don't go in quick enough, they can become septic very quickly. Actually, in residency, we had one patient who became septic, and she passed away, unfortunately. And she was young. She was like 35. So those things also influenced why I decided to do what I'm doing. Okay. All right. Let's do remind me how I.
So you should, it's open on your desktop, correct? You opened up your pictures.
Oh, yes, I remember.
Yeah. So then just share screen and it
Okay.
should go from there.
So I'm going to share some pictures of cases that I've taken care of recently. Wait, did I do the right thing?
Yes, we see those pictures.
So let's start off with this one. This was a gentleman who came in maybe about three months ago. He went to see his primary care physician because he's diabetic with peripheral vascular disease, which means poor circulation. And he had stepped on something, and he used tweezers to try to take it out. But the tweezers were, dirty. They weren't sterilized. So it became infected. So he went to his primary care physician. Primary care physician gave him antibiotics like Keflex, 10 days. He took it. His PCP told him to follow up in like 2 weeks. He followed up, but the condition looked worse. And he started having like a fever. So the internal medicine physician said, go over to a podiatrist. I feel like if we saw him early enough, it wouldn't have gotten to this spot. But that's why we do routine care for diabetic patients. But anyways, he came in. I don't know if you can see on the side, he had like a buildup of pus, but I felt like this pus was it was deep within the subcutaneous tissue. It wasn't just superficial. So I decided, because he had a fever, to go ahead and admit him to the hospital. We did an MRI, we did x-rays just to rule out gas gangrene. No gas gangrene, so it wasn't like an emergency, but it had to be drained. And MRI confirmed that there was deep abscess within the subcutaneous tissue, so it had to be drained in the OR. And I used that's another kind of the same view. I don't know if you guys can see like the sloughing of the skin and the change in the color and the swelling. All of those things indicate like infection. And it was smelly as well. So we took him to the hospital. That's the plantar aspect. Plantar means the bottom of the foot. On the side of the foot, I don't know if you can see a hole on the side. There was a wound there as well. So initially he said that he stepped on something and he tried to take the tweezers from the bottom, but I feel like whatever happened was on the side, and it created a hole, like the wound on the side tracked all the way plantar. So anyways, I use a device called pulse lavage to go ahead and irrigate it with high pressure saline infused with antibiotics to give him a good clean. So as soon as I did that, the next day his white count went back to normal. I put him on antibiotics, and then he started following up in the clinic that's not him. Sorry, let's move this inside. For routine care. No, that's not him. Okay, let me do better. Okay, let's go back up. So this is him following up probably a week later. It looks a little bit better because there is no pus oozing out anymore, but it still looks macerated, right? It looks unhealthy. So whenever he would come into the office, I would go ahead and clean out this tissue. It's called fibrotic tissue. Sorry if this grosses anybody out, but if you're in pre-med, you shouldn't be grossed out. And eventually, he kept on coming for wound care. Eventually, when the wound was clean enough, you can see it from the side. So that was deep. It tracked all the way plantar. It connected, right? And things like this, if they're not taken care of on time, would cause limb loss, right? Which we see very commonly. That's not him, sorry. So eventually I did put a skin graft on him. This is a skin graft, a skin substitute graft derived from sheep. It contains dermal and epidermal skin layers to help heal wounds. I put some skin graft on there and just watched it, weekly wound care. I hydrated the skin with some amlactin, and this is it with his follow-up visits. It took about 2 months to get to this. So this is, I kept on closing. I used also some collagen dressing, and then finally that's it. It's nicely healed. That's one case. So these are the kind of things that interest me. These are the kind of things that make me happy. That's one. I think I have time for only one more, and you know, you guys can shoot me emails or questions. This was a guy, this one, he came in because he's diabetic. These are all diabetic patients. He had a callus, a little blister on the top of his foot, and he picked on it. And as a diabetic patient with peripheral vascular disease, you're not supposed to be picking on it. Anyway, it opened up, and his PCP gave him some antibiotics. It didn't work. He's neuropathic, meaning he doesn't feel pain, but he said this was very, very, very painful. So pain is also an indication of infection if you're neuropathic. Like if you don't have sensation, then why are you in pain? So he just then decided to come in. I also sent him to the hospital. We did blood work. His white count was normal. We did an MRI. We also saw deep abscess. And so I took him to the OR to drain it. His was very quick. He came on time. After draining it, I packed it. This is the packing coming out with some betadine to kind of drain all the residual stuff in there. I sutured proximal and distal, and then he was very quick. And this was week 2, nicely healed. So after this happens, I then put them on a 3-month follow-up, make sure they're wearing the right shoe gear, make sure they're following up with me, make sure they don't pick on their calluses. I'm debriding their toenails, shaving down calluses and all that good stuff, and checking their blood flow. And I think that's it's.
There was a question asking, when you showed the packing, was someone asked if you could tell us why the nails were discolored. Was that just the betadine?
That's betadine. So before surgery, we prep the area with betadine or chlorhexidine, and that's that. The color eventually comes back.
These were super interesting. Everyone's amazed.
Yeah, this is fun. This is so exciting. Whenever I see a patient that has like nasty infection, I just envision like what I'm gonna do to get it to, you know, looking normal. It's so exciting. So, anyways, I think that's it for now, right?
Yeah, you can go ahead and I guess stop the screen share.
Stop screen share. Okay.
And then, so we have one last question for you before we let you go. What advice would you leave us pre-med, pre-health students with, especially now with COVID hopefully coming to an end? What would you leave us with?
I would say I'm happy that you guys kind of know that you want to go into the medical field. You're already doing the right thing, which is trying to get as much information as possible of different specialties to kind of guide you and make you see what you could be possibly interested in. So networking is very important. Try to get mentors, because I wouldn't have been where I am today without good advice from people. So get mentors, and just believe in yourself. You're gonna have to do that a lot. You're gonna meet a lot of stuff down the road. You're like, is this right for me? Can I do this? Like for real. Am I doing the right thing? Or man, just you have to believe in yourself. That would be my advice.
Absolutely. Thank you so much for being here. If you open up the chat, everyone's just saying thank you and they've appreciated you so much. And you've really opened up their eyes. As we said, you are our first podiatrist, so they very much enjoyed it and they appreciated everything that you brought here with us.
Problem. And all those young, sorry for cutting you off, all those people who look young and, people will question you because you look young, just use that as a inspiration to keep going.
Yes, and we love your energy so much. Thank you for being honest and just showing us to keep going and to believe in ourselves.
Yes.
But we hope you have a great rest of your day and holiday season and a happy new year.